Hi everybody, we're going to talk about pain today and the nurse's role. Some of the objectives is learning to differentiate between the different types of pain, recall the various components of pain assessment, and the factors that may influence them, determine additional assessments or teaching that is necessary based on the type of analgesic that is used, and also know the type of pain medications and their side effects, and think about educating patients in terms of side effects and how to properly take medications. Resources, ATI Chapter 4, the ATI Skill Module, Pain Management, also the ATI Pharmacology Made Easy, Pain and Inflammation, and Pellico Chapter 7. I would say that would be a good resource if you want additional reading, but I'm not committing you to read the entire chapter. So what is pain? It is defined as an unpleasant sensory and emotional experience associated with actual or potential tissue damage. It is subjective and can be known as the fifth vital sign. So it's going to be one of the components of your assessment that is subjective. You as a nurse will be able to tell other signs that somebody may be in pain or discomfort without them actually telling you, but you may also have individuals that is very suspect whether or not they're in actual pain because of how their affect may be, the way that they actually present their pain, but unfortunately in the end it is subjective, and you have to, especially if somebody is talking to you about their pain, you have to take what they're saying about their pain at face value. So the types of pain, we're looking at the duration. Acute is recent onset. It can usually happen with a specific injury. It can decrease as the healing process or artificially with medications. It can be isolated, reoccurring, or happen sporadically. Chronic, typically a time frame is longer than 3 months. You may sometimes read, others may put a time factor of 6 months, but for testing purposes we're looking for longer than 3 months. It can be associated with degenerative conditions. It can be cancer pain or non-cancer pain. Degenerative conditions can be, say, somebody with long-standing back pain, things of that sort. Cancer-related, it usually involves tumor involvement, or it can result from cancer treatments. The type of pain, the etiology, basically where is the pain stemming from? Nociceptive pain, it can be damage or inflammation of tissue that is other than that of the peripheral or the central nervous system. It's usually, a patient will describe it as throbbing, aching, and localized. It usually responds very well to opiates and non-opiate medications. Types would be bone pain, joint pain, muscle or skin or connective tissue, visceral, internal organs, stomach, intestines, and it can also cause referred pain. Neuropathic pain, this is usually damage from abnormal or damaged pain nerves. This is when a patient is going to describe their pain as intense shooting, burning, kind of like a pins and needles. So you're going to know that there's some nerve involvement. Can also include phantom limb pain, pain below a spinal cord injury, and diabetic neuropathies. And this type of pain typically will respond better to adjuvant medications. These include antidepressants, antispasmodic agents, and muscle relaxants. I'll talk a little bit more about it, but for example, antidepressants do have, kind of off-label uses that may actually address pain when it is a damage to nerves. Assessing pain, you should remember this from fundamentals. There's some different mnemonics. You have old carts or the PQRST assessment. Just kind of remember your different types of assessments when you're assessing pain. A little bit more extensive outside of old carts is old carts ice, which include ice, which is how does it impact a person's ADLs, how does a person cope with pain and emotional response. I find that this edition is usually pretty good with patients who may have either acute injuries, but it's also very good for chronic injuries as well, especially because chronic conditions will have a longer lasting impact on their lives and how they respond emotionally and cope and their impact on daily living. So when we look at the characteristics of pain, it's going to be idiopathic, where there is no detectable cause. Phantom pain is in reference to amputations. Referred pain, which is pain felt in one location but stems from another, for example, gallbladder. This picture gives you a good idea. So if somebody has some gallbladder pain or liver pain, they may actually feel it up in the shoulders, or there's intractable pain, which a person does not get any relief from any sort of treatment, and this is usually associated with some malignancies. Factors that can influence pain when you're dealing with patients: you want to consider age, culture and religion, gender, genetics, expectations of a patient in regards to what they expect their pain to be for whatever condition you may be seeing them for, experiences with pain in the past, anxiety or depression that is kind of coexisting with the pain at the time, and what a patient's support system is kind of getting through the pain of whatever issue you are seeing them for. Let's not forget non-pharmacological management for pain. There are some pains that do respond very well to non-pharmacological means, and those can be cutaneous stimulation or massage, thermal like ice and heat treatment. Remember with ice and heat treatment that you do not want to apply ice or heat directly to the skin. Make sure you do a good skin assessment beforehand. Ice or heat should not be applied more than 15 to 20 minutes at a time. And there needs to be assessment of the skin underneath. If patients start to feel any pain associated with it, then the treatment should be stopped. Transcutaneous electrical nerve stimulation or stimulators or a TENS unit can be helpful for those with some muscle pain. Distraction, relaxation techniques, guided imagery, hypnosis, music therapy, and physical therapy are some other forms of management of pain. Now, sometimes these are done in conjunction with pharmacological means, but there are certainly they can be beneficial on their own. Now, talking about pharmacological management of pain, make sure you know the different categories. We have our opiate analgesic agents. Side effects include respiratory depression and sedation, can cause nausea and vomiting, constipation, urinary retention, and pruritus, which is itching. Your NSAIDs, you want to make sure you monitor for kidney function, increased bruising or GI bleeding risk. Know your education for patients with NSAIDs in terms of GI upset, making sure that they don't take NSAIDs on an empty stomach, to watch for black tarry stools, and if they do have some kidney issues, that it may be advisable against them using it. Some patients who have had MIs in the past, it may be contraindicated for them to take NSAIDs. Acetaminophen, you want to monitor for liver function. You're going to see some different verbiage into the max amount. What it kind of comes down to is a person's health and what their liver function is, but typically guidelines have been to not exceed 3 grams, but your other readings may show 4 grams. Ms. Brandon and I have talked about this, and it's kind of 4 grams at this point, but the FDA basically would like it to be a lot lower than that. But for a healthy person, 4 grams should be the max. But those who have some liver damage, it's probably contraindicated, and if it is needed, it should be done at lower doses as prescribed by a physician. Interspinal and epidural administration, steroids, and there are some different routes of administration that you can review in your Pellico book. So one thing you need to remember, especially about your opioids, that sedation is going to happen before respiratory depression. So when you're monitoring patients, you should expect, if they're on opiates, that there will be some level of sedation. But sedation certainly comes before respiratory depression, so it will be very important to monitor the respiratory rate if you have patients that you are administering opioids to. PCA pumps, which are patient-controlled analgesia, they're small frequent dosings of consistent plasma level of pain medication, typically opioids. Patients typically feel more empowered with this type of administration because it gives them a sense of control. There's also less lag time of a patient's need and delivery, since it's basically controlled by them pushing a button. It does have a lockout feature to prevent overdose, so if patient has kind of reached their max that has been programmed, they can push that button as many times as they want. They're not going to get too much of the opioid to a point where they could overdose on it. Typical medications are going to be morphine, hydromorphone, and fentanyl are the ones that are typically done through a PCA delivery. And what is very important in terms of education, if you have a patient who has family around with a PCA, is that the patient is the only one that should be pressing the button. Hence the name of it being patient-controlled, not spouse-controlled, mom-controlled. It is the patient. The idea of a balanced analgesia is that there is better pain management with it when using 2 different types of pain medication, and that's basically different class of medications. So not the same medication in different routes or dosages. So for example, Percocet and Advil, you have an opioid with a NSAID. So you think the directions: 1 Percocet every 8 hours, 1 Advil every 8 hours. And so the way that a patient can do this, say if you're giving education, is they can take their Percocet at 8 a.m., their Advil at 12 p.m., their next Percocet at 4 p.m., and then Advil at 8 a.m. or 8 p.m. So what this does, let's see if I can get this to work right. We'll pick green. So let's say green is the Percocet, and so they take it at 8 o'clock. So this starts the med, and as it starts to peak, this is where you get the most effectiveness of it, and coming close to 12 o'clock, it's starting to dip. Then they take the next Percocet at 4 and see how its effectiveness starts to dip. So then if they're taking the Advil in conjunction with this, let's change this to orange, they're going to start taking that. Let's see here. While your Percocet is going down, they start taking that. It's going to be peaking once the other one's going down. And as it's going down, the Percocet's going up in the effectiveness. And there's the Advil. So you see here, why it is effective to use 2 different types of pain medications, and they can take at the same time, just at different time periods. So as the effectiveness of one starts to decline, say in this area here, is the thought that the other is kind of getting to its peak effectiveness. And so as that one starts to wane, the patient has taken the other one and it increases. So when we talk about pain medication, here is an example of all the different pain medications that can be prescribed to a patient. So over the past weekend, Bob hurt himself while trying to move a large heavy box from an overhead storage area in his garage. He now has spasms in his left shoulder and a tingling sensation in his left arm. His doctor suspects a mild impingement. So here are all the different medications that are prescribed to Bob. He is given Ultram, which is also known as tramadol. He's given cyclobenzaprine, Flexeril, which is a muscle relaxer, a Medrol dose pack, which is a steroid, and he's also given meloxicam or Mobic, which is an NSAID. And so what you have to realize is that with pain, a lot of different things can be happening. You can have pain itself, you can have pain that's coming from inflammation, and so your Medrol dose pack and your Mobic, which is an NSAID, so steroid and the NSAID will help address any inflammation. Flexeril, that's a muscle relaxant that's going to help with any spasmings that is happening from the muscles that will calm those nerves down, which also causes pain. And then Ultram tramadol, which is a non-opioid, it will help address pain as well. So we're talking about teaching assessments or considerations. Giving anybody tramadol, you want to make sure the patient does not have a history of seizures because it does lower the seizure threshold. It does cause CNS depression, so you need to educate the patient about that because they will have depression versus it can lower their respiration rate. Flexeril, there is caution with some other CNS depressive medications. So since this is a depressive, you should advise the patient not to take the Flexeril at the same time as the tramadol. So they should take these at different times, at least a couple hours in between. The Medrol dose pack, make sure that patients complete the course since it is a steroid. And if you have any diabetic patients, they should be advised to closely monitor their glucose levels because steroids will increase their insulin resistance and their blood sugars will be elevated. And then with the Mobic or meloxicam, it is an NSAID, so you want to talk to patients about the GI risks, make sure that they take the medication on a full stomach with food, and also, like I said, with the cardiovascular risks, if they have a history of MI, it should probably be contraindicated and not to take with other NSAIDs or over-the-counter NSAIDs like Motrin, Advil. Make sure your patient knows what the different NSAIDs over-counter are because there are some different names. Other approaches, neurological, neurosurgical approaches like stimulators, intraspinal and epidural administration of opioids, and ablation, which just basically deadens the nerve. That can be either done with cold or heat. Big problem when you're dealing with patients is understanding the difference between drug tolerance versus dependency. Tolerance basically is a lower response to repeated administration. Patients typically need increase in dose or frequency, and it's usually seen in opioids, nitrates, and barbiturates. Now, dependency, though, basically takes a drug beyond its intended use, and it can lead to difficulties with withdrawal. So there's a difference between a dependency and a tolerance. So make sure you know the difference between the two. Unfortunately, here in the state of South Carolina, we do have an opiate overdose, and it's actually surpassing homicides. In 2015, the number of deaths from heroin and opiate overdose in South Carolina has surpassed the number of homicides. There is now a task force which is called the LEON program, which is Law Enforcement Officers Naloxone program, and this basically allows law enforcement to administer naloxone if they suspect an opiate overdose. I don't know how many of you watch the live PD show on TV. Unfortunately, I watch it from time to time because I find it very interesting, but there was actually a case that an officer was called to where a few people saw somebody fall off a bench outside and they thought that the person was dead. And when the officer arrived on scene, the person was not breathing, non-responsive, and so the officer actually started doing chest compressions, and when the EMT showed up, they went ahead and just gave him naloxone, and you saw watching this that within minutes that he was actually coming to, and so his life was basically saved from naloxone or Narcan, and you will see people respond very quickly to that. But unfortunately, here in South Carolina, it is an epidemic. So the meds you need to know your antidotes for acetaminophen poisoning, know Tylenol, know your aspirin, not to avoid giving that to children, know your NSAIDs, your Advil, your Motrin, your ibuprofen, know that it can cause GI upset, morphine, monitor for respiratory depression, watch for nausea and vomiting and constipation, and Narcan, naloxone, which is an antidote for opiate overdose. These are just kind of a short list, but make sure you are familiar with these meds. Don't slack. Make sure you review your ATI modules that have been assigned and take time to learn your pain medications, because no matter what type of nursing you do or where you go, you are always going to run into a patient with pain. If you have any questions, let me know.